My name is Maria Lockage, and my case presentation is on the disorder Myasthenia Gravis. Typical patient presentation. A 47-year-old white man presents to his physician with complaints of muscular weakness that worsens over the course of daily activities, specifically weakness of the eyes, limbs, occasional difficulty swallowing, and a constant soft cough. He claims that these symptoms are almost not present in the morning after he's had a long rest. Etiology of myasthenia gravis. It is caused by an autoimmune disorder in which antibodies work against the neurotransmitter acetylcholine and its receptors at the neuromuscular junction. It is specifically caused by a defect in nerve impulse transmission, and therefore the acetylcholines aren't recognized as self-receptors and the muscle cannot receive a signal to contract, also known as decreased muscle depolarization. The term idiopathic means that the cause of the disorder is unknown and it arises spontaneously. One theory of myasthenia gravis is that certain viral and bacterial proteins may prompt the body to develop the self-antibody. Myasthenia gravis is not a common disorder. The incidence is 9 to 21 cases per million people, and then it is more common in women rather than men for unknown reasons, as are most autoimmune disorders. They're more common in females. Most myasthenia gravis patients live a normal lifespan. Mortality is low because cases are confined to facial muscular weakness, which is not a life-threatening sign or symptom. The most effective muscles include those of the eyes, face, mouth, and throat. And then less frequently affected muscles are of the neck, shoulder, hip, and respiratory system, and if affected, these are usually more serious. Other impacts that myasthenia gravis can have on the patient are thymic tumors, pathological changes in the thymus, and then other autoimmune disorders may arise. About 10 to 20% of myasthenia gravis patients are associated with thymomas. These are tumors of the thymus. Risk factors. There's no specific age at which myasthenia gravis starts or ends at. It can occur at any age, but for women, they're most commonly affected at 40 years or under 40 years, and for men, they're affected most commonly at 60 years or over 60 years. Myasthenia gravis is common after sepsis, which is a life-threatening condition after any sort of severe infection. Another risk factor is a post-surgery morbidity, which is, an example includes patients who undergo thymectomy, which is a surgery recommended for myasthenia gravis patients. They are then at a risk of developing additional myasthenic crisis, which is a severe form of myasthenia gravis that can occur, turning it into a life-threatening condition which requires immediate medical attention and treatment. And then specifically thymectomy is a trigger for myasthenic crisis, which is why it is a post-surgery morbidity risk factor. The pathophysiology of myasthenia gravis largely revolves around the blockage of the acetylcholine receptor. In the first picture on the left side, you can see acetylcholine coming out of a neuron as the signal. It is traveling to the acetylcholine receptor, and then it functionally connects to it and is able to send the signal onto the neuromuscular junction. And then on the right side, in the second picture, you can see also acetylcholine coming out of the neuron in that upper structure. It attempts to attach with the neuromuscular junction acetylcholine receptors, but there are antibodies, the green structures, blocking those receptors, so there is no transmission occurring in that muscle. When talking about the pathophysiology of this disease, it is important to think about the significance of acetylcholine in the body. And the significance is that acetylcholine as a neurotransmitter causes muscles to contract, it activates pain responses, regulates endocrine, involuntary functions, the REM sleep functions, and therefore a decrease in acetylcholine leads to muscular weakness, which impairs almost every system of the body. Pathophysiology continued. The autoantibodies present in myasthenia gravis patients play a major role in the disease pathomechanism by reacting with acetylcholinease receptors. Cases are present where people do not have acetylcholine antibodies, which is the common presentation, but instead antibodies against something called muscle-specific receptor kinase. Muscle-specific receptor kinase is another component of the muscular membrane. Therefore, myasthenia gravis will exert its same weakening effects via impairing transmission of the neurotransmitters. In this picture, you can see another representation of myasthenia gravis. Acetylcholine is attempting to attach to the muscular membrane in the neuromuscular junction, but there are blockages, those little Y-shaped structures on the muscle, which are not allowing the acetylcholine to attach and send its signal. In the lady's face on the left side, we can see that this is exerting an effect of ptosis, which is an abnormal drooping of the eyelids. And then in the picture on the right, we can see that the axon, which is attached to the bicep muscle of the man, is the structure that's supposed to send the signal from the brain to the muscle to contract. But in this case, the myasthenia gravis will impair that from occurring, causing weakness of that specific arm muscle. Symptoms. One symptom that is present in all patients affected with myasthenia gravis is the fluctuating fatigue of skeletal muscles, such as the limbs. Here I say fluctuating because, for example, after a long rest, such as overnight sleep, there is a restoration of the acetylcholine receptors and the neuromuscular junction, and therefore they are not blocked by antibodies, so the muscle is able to contract. This usually worsens throughout daily activities. Another symptom is ocular diplopia and ptosis, which is the drooping of the eye muscles as mentioned previously. Then there's bulbar diplopia. This affects only 15% of patients. They experience weakening effects of bulbar nerves, including slurred nasal sounding speech, sometimes difficulty swallowing, and choking. Another symptom is dysphagia, which I mentioned, difficulty swallowing, dystonia, hoarseness, and coughing if the respiratory muscles are involved. And this is in more serious cases, and if so, the patient may have difficulty breathing, and it occurs in the late course of myasthenia gravis. It never shows up first. Diagnosis. The diagnosis of myasthenia gravis is made clinically. One of the tests is the Tensilon test. Tensilon is a drug that is administered intravenously, and it is supposed to differentiate myasthenia gravis from other disorders to see if you will be diagnosed with myasthenia gravis. Tensilon works by inhibiting acetylcholine esterase, allowing acetylcholine to bind to existing receptors as much as possible, and during this test, the doctor may require the patient to participate in physical activity to see whether the reverse effect occurs. The Tensilon effect usually lasts for only about 10 minutes. The ice pack test also determines whether a patient has myasthenia gravis. This test is when an ice pack is applied to the eyelids, and after a while, there should be improvement of the ptosis and diplopia of the eyes, concluding that the patient does have myasthenia gravis. Additionally, an electromyography may be done to assess the activity of muscles, and serum could be tested for detection of anti-acetylcholinease receptors or other anti-muscular receptors. A very common initial test includes the repetitive nerve stimulation test, where a doctor or physician might have the patient repetitively use a muscle until fatigue occurs. There is neurological exam, which checks reflexes and muscle tone. There is the testing of motor function in different body parts. And lastly, observing eye movements. Treatments for myasthenia gravis can be grouped into 4 general types, the first being symptomatic treatment with the goal of increasing available acetylcholine at the neuromuscular junction. An example is pyridostigmine. This is an acetylcholinesterase inhibitor which slows down the degradation of acetylcholine. The second is chronic immunosuppressive therapy. The goal here is to target immune system dysregulation. If pyridostigmine is not effective, nonsteroidal immunosuppressive agents are administered to spare glucocorticoids, which are usually used up first by the body's metabolism. The third is immunomodulating treatments. These are rapid response treatments. An example is plasma exchange. Plasma exchange acts quickly but is not long-term, therefore it just modulates the immunosystem temporarily. The last is surgical treatment, and this is required if no other treatment or therapy is effective. The most common is thymectomy. Even if a thymoma, a tumor of the thymus epithelial cells, is not present, thymectomy is recommended for any patients who are at high risk of developing myasthenia gravis. Treatments can be split into non-surgical and surgical types. Non-surgical treatments have the goal of decreasing myasthenia gravis symptoms and minimizing as many side effects from medication as possible, both at the same time. Examples include the pyridostigmine that was mentioned earlier, the plasma exchange, suppression of the immune system, and sometimes even ventilatory support for those whose respiratory muscles are effective and breathing is labored. The only surgical treatment is a thymectomy, and this is removal of the thymic tissue to reduce generations of cells against acetylcholine receptors. These are my references. Thank you for your attention, and I hope you enjoyed this overview of myasthenia gravis.